Okay, welcome back everyone. I'm Dr. Dalia Al-Mafti, an assistant professor from University of Chicago, and I'm discussing pain management in painful disease states. This will lead us into our next topic of discussion. A 48-year-old man presents with a 6 months history of right lower sided back pain. He has had an ache for many years, but the pain became worse after shoveling last winter. He has tried physical therapy and multiple medications, including steroids, nonsteroidal anti-inflammatory drugs, and muscle relaxant. An MRI shows mild degenerative changes. There are no abnormal neurological findings on exam. The interventional treatment most likely to provide sustained benefit for this patient is A. A lumbar epidural steroid injection at L5-S1. B. Trigger point injections at the lumbar paraspinal muscles. C. Radiofrequency ablation of the lumbar facet joints. Or D. psoas compartment block. The correct answer is C. Radiofrequency ablation of the lumbar facet joints. Basically what the patient is describing is localized low back pain that is not radiating into the lower extremities, worsened with shoveling. So when we're shoveling, we are stressing those facet joints. The radiofrequency ablation would be the ultimate procedure that would be performed, but prior to doing this procedure, we usually perform diagnostic blocks, and if those provide relief, then we proceed to radiofrequency ablation. A. Lumbar epidural steroid injection. The patient doesn't describe a radicular pain, meaning he does not describe pain radiating down the leg that follows a dermatomal pattern. So that might not be as beneficial for the patient as a lumbar facet injection. Trigger point injections to the paraspinal muscles. Trigger point injections may provide relief, but not necessarily the most correct answer because it may not provide sustained benefit for the patient. And D, psoas compartment block. This block is typically performed as a regional anesthetic, and there's no documentation of long-term benefits for chronic back pain. The facet joint. We talked about it earlier. Basically, the facet joint is a true synovial joint, and it's formed of the inferior articular process of the vertebral body above and the superior articular process of the body or vertebral body at the level. And it receives innervation from the vertebral body above and the vertebral body below. And as we mentioned earlier, it's a common cause of low back pain, and as well as chronic neck pain after whiplash injuries. Basically, what's done prior to proceeding to radiofrequency ablation is a diagnostic block in which we basically inject a local anesthetic and see if the source of pain is coming from the facet joint. If patient does have relief, at that point we go and perform radiofrequency ablation at the median branch. The literature out there is mixed regarding efficacy. There's some literature that shows moderate short to long-term benefits. If the patient had pain radiating down the leg that follows a dermatomal pattern, at that point we can consider an epidural steroid injection. Now, the first published case of sciatica was in the 1930s, and basically what sciatica describes is pain radiating down the sacral plexus. For radicular pain, as many of our pain states, conservative treatment is recommended. If that is ineffective, then we can proceed to more interventional treatment options. We talked a little bit earlier about some of the conservative methods for radicular pain, which included physical therapy, some of our neuropathic agents such as our anti-epileptic drugs, and certain scenarios, anti-inflammatories such as a tapering dose of steroids. There is some literature out there that shows that it has moderate short-term benefit. We have to be careful with patient selection. As we mentioned, interventional procedures can come with side effects. Again, although they might be rare, it is important to appropriately choose your patient population. There have been case reports of catastrophic events that have occurred after interlaminar or transforaminal approaches, paraplegia, especially when it's performed in the cervical area. Okay, now we're going to shift our discussion to treatment modalities and different types of regional techniques that can be performed. Start off with a question. With a midline approach, after advancing the needle tip just beyond the posterior tip of the spinal process for intrathecal anesthesia, the structure the spinal needle will next enter is most likely A. Supraspinous ligament, B. Interspinous ligament, C. Ligamentum flavum, or D. Transverse process. The correct answer is B. Interspinous ligament. Supraspinous ligament is between the tip of the spinal processes. Interspinous ligament is in between the spinal process. Ligamentum flavum is the posterior border of the epidural space, and transverse process is a bony structure of the vertebral body. So if you look at this table or this diagram, this is basically structures you encounter as you go from more superficial to deep. Obviously, the first structure you're going to encounter is skin. After that, subcutaneous tissue. After that, supraspinous ligament, followed by the interspinous ligament, and the ligamentum flavum, which is again the posterior border of the epidural space. Then the epidural space. Epidural space contains connective tissue as well as vasculature, both veins and arteries. After the epidural space, you'll have your dura. And after the dura, there's a potential space that can be created, which is called the subdural space. There's an anatomical variation from person to person. Some believe that the subdural space is created by a shearing mechanism of introducing and removing the needle multiple times. After the subdural space, you have your arachnoid, and then your intrathecal or subarachnoid space. When we're talking about intrathecal anesthesia, certain medications will have variable length of action. Some of the local anesthetics that we use in our intrathecal anesthetics include lidocaine, ropivacaine, or bupivacaine. And again, their duration of action can be variable depending on the concentration and the amount that's placed. With intrathecal anesthesia, there are certain patient characteristics, as well as local anesthetic characteristics, technical variation, and CSF characteristics that can affect the level of the block. When we refer to patient characteristics, patient's height and weight plays a role. The spinal canal volume plays a role, and the presence of intra-abdominal pressure. For example, a parturient or a pregnant patient has increased intra-abdominal pressure that may reduce her epidural and intrathecal volume. So basically what that means is a little bit of local anesthetic goes a long way in this patient. The spread of the local anesthetic, the spread or the level can be dependent on the local anesthetic characteristics. Depending on the baricity of the local anesthetic, whether it's hyperbaric, isobaric, or hypobaric, will determine whether the medication will rise against gravity or towards gravity. Concentration and the volume and the force of which the volume was injected also plays a role. Technical variations, meaning the way you position your patient. For example, if you're injecting a hyperbaric solution, if you place the patient, for example, in a Trendeling position, that will allow that hyperbaric medication to go above the level of the umbilicus. CSF characteristics also play an important role. As we mentioned earlier, the CSF volume plays a role as well as the density and the circulation. So patients that, for example, may have some obstruction to flow, that may alter your level of block. One of the side effects that can occur when we're performing intrathecal anesthesia is a post-dural puncture headache. And basically, this refers to a headache that can occur due to change in CSF pressure. How this occurs is obviously to reach the CSF, you have to perform a dural puncture. And through that dural puncture, there can be leakage of the CSF fluid. And again, that can result in lower CSF volumes that can lead to traction of some of our subdural veins and meningeal irritation, which can present as a post-dural puncture headache. Oftentimes, patients will complain of frontal occipital headache, sometimes ringing in the ears, sometimes blurring of vision, depending on the degree of CSF volume loss. Management of post-dural puncture headaches oftentimes is conservative with appropriate hydration and caffeinated beverages. If patient continues to have persistent symptoms, then at that point an epidural blood patch can be considered. And basically what that involves is taking a certain volume of patient's own blood, autologous blood, and injecting it in the epidural space with hopes to increase the CSF pressure and possibly occlude the patch that was created. All right, this will lead us into our next topic. Which of the following most likely represents a contraindication to placement of an epidural catheter for analgesia? Is it A, the INR, International Normalized Ratio, of 1.3, B, chronic methadone treatment for vascular claudication and chronic pain of the lower extremities, C, need for postoperative DVT prophylaxis with enoxaparin, 0.5 milligram per kilogram, sub-Q daily, or D, aspirin and Plavix treatment for coronary artery disease with a recent stent. The correct answer is D, aspirin and Plavix. There have been a series of guidelines that have been published that help practitioners determine anticoagulation status in patients receiving regional anesthesia. Most recent guidelines were in 2010, and then again, I believe it was in January 2015, there was another set of guidelines that were published. Clopidogrel and aspirin are contraindicated in the use of neuraxial treatments because it can increase the risk of bleeding. It's usually recommended that clopidogrel be discontinued for 7 days. In reference to aspirin, it itself doesn't necessarily increase the risk, but may increase the risk in certain patient populations, such as patients who have severe spinal stenosis or who have had prior back surgery. If aspirin is being used for primary prophylaxis, then at that point it might be wise to consider discontinuing it. If it's used for secondary prophylaxis, then at that point you need to consult with the neurologist or the cardiologist regarding recommendations whether or not it is appropriate to discontinue the medication. A would be incorrect. The ASRA guidelines suggest that there is a limited increase of epidural hematoma with an INR of 1.5. Actually, with the new guidelines that will be coming out, or actually are out, an INR should be within normal. Patient should not have any anticoagulation issues if you're going to be placing an epidural. Chronic methadone for vascular claudications, that is not a contraindication for the placement of neuraxial. The need for postoperative DVT prophylaxis, 0.5 milligram per kilogram daily. That's usually considered a prophylactic dose. So it's not necessarily contraindicated with the placement of an epidural, but timing of the placement is important. Prophylactic enoxaparin should be discontinued 12 hours prior to placing, and if you do need to reinitiate it, it should be reinitiated at least 4 hours after. So what are the contraindications to neuraxial anesthesia and analgesia? Of course, number one, patient refusal. There are some relative contraindications based on your patient's comorbidities, being hypovolemic, as again, the neuraxial procedures can cause a sympathectomy. Infection may be a relative contraindication. If it's at the site of where your needle entry point, it's probably not wise to proceed. The presence of bacteremia and sepsis can be a contraindication. And as we mentioned earlier, coagulation deficits and platelet dysfunction. Again, with any procedure, there are always risks. We earlier talked about the risk of post-dural puncture headache, and we talked about some of the presenting symptoms and the management, meaning conservative management and possible epidural blood patch. Some of the other risks with neuraxial procedures include the risk of infection, although it's rare, it has been reported. Development of meningitis, epidural abscesses, and supraskin infections have been reported. Neurological complications as well. Anytime we're working by neuraxium or the spine, there's always a risk of nerve injury. The nerve injury can be a result of direct needle trauma or neurotoxicity from the substance that could have been injected. Patients who do receive neuraxial need close management and close following to make sure that they do not develop any persistent paresthesias or motor weaknesses. When there are some reports of the use of lidocaine and the development of transient neurological symptom, which basically is ongoing pain in the perineal area. And it's not quite sure if it's related to the lidocaine or the use of small bore catheters that can traverse retrograde and cause pooling of the local anesthetic. We talked earlier about some of the ASRA guidelines that have been published on the use of anticoagulations and regional anesthetics. It's very important to understand your patient's comorbidities and medications that can alter bleeding profile. As epidural hematoma, in the past it's been reported to occur in 1 in 150,000, but some of the more recent studies show that it can be as common as 1 in 3,000. Some of the most common presentations that can present when a hematoma is developing is the presence of back pain, which then can lead to radicular pain, which then can lead to motor and sensory deficits. We have a very narrow window for treatment of this event. If it occurs, it's usually a 6-hour window. Emergent MRI or CT scan must be performed to identify it, and surgical consultation and possible decompression if indicated. Earlier we talked about certain medications that can increase the risk of epidural hematoma. There were several case reports that describe the presence of hematoma with the use of Lovenox or enoxaparin. It's also been quoted that it can increase the risk by 50%. So as I mentioned earlier, ASRA, American Society of Regional Anesthesia, has developed consensus guidelines. They usually do not recommend the use of prophylactic Lovenox with an epidural catheter in place. If the decision is to administer therapeutic enoxaparin on a patient, then the catheter must be removed. Regarding to discontinuing, if a patient is on enoxaparin, prior to placing the catheter, therapeutic dosing, it has to be held for 24 hours. If it's prophylactic dosing, it has to be held for 12 hours. It can be reinitiated after removal of the catheter. There was a new FDA warning that came out that basically recommended 4 hours reinitiation after the catheter has been removed. And there are certain patient comorbidities or factors that can increase the risk of spinal hematomas. We touched base earlier on some of these. Patients that have certain back comorbidities, meaning those that have spinal stenosis, there can be an increased risk. And those that have increased age, because those that are advanced in age are the ones that are most likely to have degenerative disc disease and spinal stenosis. Certain anesthetic factors can play a role. Multiple attempts at placing the neuraxium, traumatic needle placement as well can increase the risk factor. And as we talked about earlier, keeping an indwelling catheter on medications that can increase the bleeding profile. We already discussed low molecular weight heparin and how it increases the risk of bleeding with neuraxial procedures. So regarding epidural analgesia, what medications do we use? There's a combination. Some of the literature shows that there is a synergistic effect when you use a local anesthetic and opioid. Some of the local anesthetics that we use include bupivacaine or ropivacaine. Some of the opioids that are used include hydromorphine, fentanyl, and morphine. How you determine which one you're going to use depends on the dermatological coverage that you need. For example, the opioids, some of the opioids are more lipophilic versus hydrophilic. The lipophilic will provide more of a segmental spread, meaning staying at the level or at the mu receptors, the dorsal horn near the area that's going to be operated on or that has chronic pain issues, while some of our hydrophilics, such as morphine and hydromorphone, will have more of a cephalate spread, meaning capturing more of our mu receptors. The concentration of the local anesthetic, again, depends on your patient's comorbidities. If you have a patient that is hypotension, at that point you might want to consider using a local anesthetic that is less concentrated to avoid that sympathomimetic effect. Multiple ways you can run an epidural analgesic. You can do a continuous infusion or bolus infusion. And the rate of the infusion really depends, again, on the dermatomal coverage and the placement of the catheter. Epidurals are commonly used for perioperative time frame. There's some literature that shows some benefits in the perioperative time frame. Of course, we know it can help reduce the opioid-related side effects. The less opioids, the less postoperative ileus that can occur, the less nausea and vomiting, and the less the patient is in pain, the better breathing pattern that they may have. There are also some literature out there that it can help reduce the risk of MI, but that's not in a epidural that's placed in the lumbar area. That might be in an epidural that's placed higher up in the thoracic, as it can increase coronary perfusion. Some alternatives to epidural analgesia include paravertebral blocks, intracostal or intrapleural blocks, and those again can help provide analgesia at the dermatomal site that you want covered. All right, another question. Which of the following regarding placement of epidural catheter is most likely true? A. Loss of resistance to air techniques have been proven more successful to avoiding dural puncture. B. Use of a paramedian technique should avoid the needle contacting with the spinal process. C. Epidural catheter placement for a right thoracotomy involves placing the needle 2 vertebral levels above the level of the iliac crest. Or D. A test dose of 3 ml, 1.5% lidocaine with epi should be produce a anesthetic band over the desired surgical level. The correct answer is B. The use of a paramedian technique should avoid needle contact with the spinal process. A is incorrect. There isn't any literature that shows loss of resistance to air versus saline is more superior. C. Epidural catheter for a right thoracotomy being placed at L3, that's at the level of the iliac crest. That is too low to provide coverage. Ideally, you want it in the thoracic dermatomal area. D is incorrect. 3 mLs of 1.5% lido with epi may not sufficiently produce an appropriate surgical level. As we mentioned earlier, you usually require 2 to 3 mLs for one dermatomal level or vertebral body level. Epidural factors, things that influence the block, duration of action, a little bit different than our intrathecal anesthesia. As I mentioned, with intrathecal anesthesia, baricity affects the level of spread or the level of blockade. Positioning can affect. With epidural analgesia, that's not necessarily the case. Position, height, weight have minimal effects. And as we mentioned earlier, for every dermatomal level, you need at least 2 to 3 mLs to block that dermatomal level. There's some additives that can be added that can help prolong sensory and motor block. And as you go up from lumbar to thoracic to cervical, there's actually a reduction in the epidural space and epidural volume. So that basically means you need less local anesthetic. These are, again, some of the adjuncts that can be placed. We already talked about the main medication that's usually placed in neuraxial procedures or neuraxial infusions, a local anesthetic. Sometimes we can add an opioid such as fentanyl. There are some other agents, clonidine, epinephrine. Clonidine, again, you can place anywhere from 15 to 45 mics. There's some literature that shows that it increases motor block as well. With the epinephrine, anywhere from 0.1 to 0.6 milligrams can be placed neuraxially. And again, there's some literature that shows that it can increase motor block. Some of the side effects, as we said, anything opioids that are given intravenous or neuraxial can cause itching. That is one of the most common side effects with epidural analgesia is the itching. Sometimes that can be blocked by as we mentioned earlier, giving a partial agonist-antagonist such as Nubane, or even there's some literature where naloxone infusions have helped to reduce the incidence of nausea, vomiting, and itching. Benadryl or diphenhydramine is one of the most common agents that is also administered for itching from epidural analgesics. Next question that will lead us into our next topic. Which of the following regarding caudal epidural anesthesia in children is true? A, it is a rare use of a regional technique in the pediatric population. B, epinephrine should not be injected into the caudal epidural space in children. C, maximum injected volume is 0.5% bupivacaine at 1 cc per kg, or a maximum of 30 cc's. Or D, the needle will pass through the sacrococcygeal ligament to enter into the space. The correct answer is D. The needle is passed through the sacrococcygeal ligament to enter the space. A is incorrect. It's actually a very common procedure, a regional procedure that's used for pediatric surgery. B is incorrect. Epinephrine can be injected and actually should be injected to rule out an intravascular placement of the neuraxial procedure, the epidural or the epidural catheter. C is as well incorrect. The dosing is incorrect. The maximum injected volume is using 0.25%, 0.25% at 1 cc per kg, or a maximum of 30 cc's. So what is the caudal epidural space? Again, basically, it's a effective and safe analgesic way to provide pain relief for pediatric patients that are undergoing procedures in the pelvic area, the lower extremities. The caudal epidural space, access to the caudal epidural space is going through the sacrococcygeal ligament. Basically, how this space was created is that the spinal process of the S4 and S5 vertebral body are not formed. Instead, the little nodes are formed on the side called the sacral cornu, and that's covered by the sacrococcygeal ligament, which is an extension of the ligamentum flavum. Oftentimes, a catheter can be placed to provide a continuous infusion to help with postoperative pain management for pediatric patients. As well, another form of a caudal epidural injection is a caudal epidural steroid injection, which can be used for chronic pain and lumbar radiculitis, especially when sacral nerve roots are irritated. This is an image here of a caudal epidural steroid injection. You see on the left side is an AP image, and on the right side is a lateral image. On the right side, you can kind of see a Y-shaped formulation. The entry to this epidural space, or the caudal epidural space, is where you see the hyperechoic or the radiopaque line entering there. Quickly touch base on peripheral nerve blocks. We've been talking about some of the perioperative pain management techniques and regional techniques. Peripheral nerve blocks have become more and more common to help control pain after surgery. There are several different types of peripheral nerve blocks. There's upper extremity, lower extremity, and truncal blocks that can be performed. With most of our peripheral nerve blocks, we are using a local anesthetic. And there is literature out there that shows that the use of a peripheral nerve block, again, can help reduce opioid consumption in the postoperative time period and also help prevent the occurrence of chronic pain after surgery. Last topic, treatment modalities and non-pharmacological techniques that can be utilized for pain management. Physical therapy is one of the most important aspects of a multidisciplinary approach. We can use passive or active forms of physical therapy. Passive form include heat, deep tissue massage, or ultrasound massage. Now, yes, this just provides temporary comfort, while active forms such as strengthening exercises, body mechanics, and ergonomic training, as well as posture awareness training, there's literature there that shows that it actually improves pain and functionality levels in patients. Other treatment modalities include the TENS, otherwise known as the transcutaneous electric nerve stimulator. Now, the TENS unit is kind of a primitive form of neuromodulation that we discussed earlier with spinal cord stimulation. Basically, it's a device that has pads that can be placed in the area that's bothersome, and it creates a vibratory type sensation. And again, it has that same concept of neuromodulation where we're stimulating a non-painful fiber, and hopefully that'll help distract against painful fibers. It is contraindicated in patients who have pacemakers, so you need to be aware of that. Other modalities that are quite important in the treatment of chronic pain include psychotherapeutic measures. This is one of the most important aspects when managing chronic pain and introducing it as part of your treatment modalities. Some examples of psychotherapeutic treatment measures include cognitive behavior therapy, where basically we're trying to address that maladaptive emotional behavior response to pain and make it a more adaptive response. Biofeedback basically involves voluntary control of certain involuntary processes, such as trying to reduce muscle tension, neck tension. Hypnosis basically involves the attention focusing component, where when patients are in pain, you try and have them focus on non-painful stimuli. And apparent behavior therapy basically involves helping eliminating that negative learning behavior that's developed over time. That kind of concludes our discussion.